Okay, this video is called Why I Changed My Mind About AI and Radiology. I used to think, first of all, it's just a joke. And I still think it's a joke. Okay, that was number one. Number two, I used to think it was just a bad thing. You know, more nonsense and crap that's just going to be used to rip off patients. Okay, but now why do I think, and maybe there's something good about it? Well, what I've heard from a couple doctors is that medical students don't want to go into radiology anymore. They've been told that artificial intelligence is going to take over radiology, and because of that, they don't want to go into it. So I've heard even some good residency programs are not able to attract residents, and I think that's kind of funny. I'll tell you why I think it's funny. Because radiology is sort of like a big Ponzi scheme. There's tons and tons of patients come in for, to be evaluated in the emergency room or through screening studies, and they get a CAT scan of the chest, abdomen, and pelvis. A chest, abdomen, and pelvis CT is called a body CT. The brain and the spine is a neuro CT, and the neck, okay? The joints, the arms, shoulders, hands, wrists, ankles, that's called MSK, musculoskeletal. The reason I'm telling you this is the old joke in radiology is, what's the definition of a healthy person? Somebody who hasn't had a body CT yet. The reason is there's almost always at least one, if not two, three, or four incidentalomas. Small lung nodule, follow-up CT in 6 months. Too small to characterize lesion in the liver, get a liver MRI, okay? Lesion in the kidney, get a kidney ultrasound. Sclerotic bone lesion, get an MRI of the spine. The reason I'm telling you all this stuff is because once a patient gets one set of pictures, I joke that it's like Hotel California, they very often need to get more pictures and more follow-ups routinely for 2 years, sometimes as long as 5 years. That generates a lot of business. So the volume in radiology departments is always going up, 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 up. That means more work. So if you're a radiologist, like I'm an old-time radiologist, I'm tired, okay? I don't want to work so much. I want time to write my books, but the volume of work just keeps going up, 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 and up. And radiologist is like Charlie Chaplin in modern times on the assembly line. Go faster, go faster, go faster. We just got to crank them out. But why am I telling you all this? Because think about it if you're a young guy. What would be a good field to go into? Something where the volume is going up through the roof and simultaneously they have a shortage of workers, so they need more people. Okay, the starting salaries in radiology are so high that I'm embarrassed to say it. I'm embarrassed to say it because I know most people don't really understand it and they're going to freak out. But they also don't understand a radiologist, a new junior guy trying to make partner, is going to work twice as hard as a regular person. Some regular person going to some cushy librarian job, they're not going to get paid much, but it's going to be very pleasant, okay? 8-hour shift, go home. Whereas a new junior person trying to make partner in some busy group, they're going to be working 10, 11-hour days, taking lots of night calls, sleep-deprived, exhausted, lots of med-mal-pral risk, lots of pressure to go faster and faster and faster, to learn more stuff, to be able to handle more responsibility and pressure. So it's not a party. Some things I've seen also, they had EKG machines that could read EKGs reasonably well back in the 1990s, but they still keep a doctor's name on there because the lawyers want to have somebody to sue. They want somebody to be liable for that. So I would expect the same thing is going to happen in radiology. They're not going to want some machine on there. You can't sue the machine. And also, what people don't understand, it's not like this finding plus this finding equals this disease. There's tons of artifacts on the films. There's tons of noise. There's motion artifact, metal artifact. It also, you have to know the social background of the study. Not only what is the patient's age, history, etc., comorbidities. You got to know who's the doctor that's ordering. Like I know some doctors, they don't really know what they're ordering. In almost every case they have, it's going to be normal. So I'll always lean towards thinking their patients are normal. I know other doctors that only send me patients usually when they're pretty sick. So I'm going to be more worried that there's really a significant finding on those patients. Go by the patient's age. The same finding in a 20-year-old is much more important than it is in an 80-year-old. I know this 80-year-old guy is going to be dead within 10 years because he's got all these other terrible diseases, congestive heart failure, metastatic cancer, okay? So I don't care about a thyroid nodule. But a thyroid nodule in a 20-year-old, I got to make sure I call it because that's going to need to be followed for decades. Okay, so knowing the social aspect of things, makes a big difference. And there's tons of what we call borderline findings, border zone findings, meaning could be a normal variant in one context, could be abnormal in another context. Okay, you have to know all that stuff And a lot of that comes from experience. When I first got out of my fellowship training, I had crushed my boards, perfect score on my boards, and I thought I was a pretty smart guy, and I would come to work in a big group, okay? And the old guys would call me, ask me, hey, Pete, how would you describe this? How would you describe this? And I was pretty confident. I could describe everything precisely. I knew all the classification system for the fractures, the tumors, the other diseases, etc. But then I noticed something. I was calling the old guys to help me more than the old guys were calling me to help them. And the reason was I knew all the terminology better than they did. I had better, longer differential diagnosis, but they were way better than me at a more common problem. Is this normal or not? There's tons and tons of stuff that isn't in any book that you only know from having seen 1,000 brains, 1,000 spines. Is this normal or not? And the old guy will say, that's normal. I see it all day, every day. Okay, but a young guy doesn't know that. So that's why that tacit knowledge that the old guys have is super valuable. It's essential for good interpretation of films, okay? And that clinical experience they've seen something that only happens 1 in 10,000 patients. They've seen it. They immediately know what to do. The young guys only heard of it in a book, okay? So old guys know a lot from that type of experience. So the bottom line is, I think, you're going to have to work like a maniac in radiology. You can find an easy subspecialty. Nuclear medicine's got much better hours. Same thing with mammography, but mammography's boring. Nuclear medicine's interesting because you can read the PET scans. Lots of women go in MSK because there's not much emergency, so they can get home in a predictable hour, see their kids. I went into neuro. It's actually like that and IR. I did the two hardest things, interventional and neuro, because they're the most interesting, but they're also the most brutal. IR is more brutal than neuro. Long hours, working with all the radiation machines, you got to be really careful. Neuro's brutal because tons and tons of stat emergencies. I've had days where I read 15 emergencies in a row. But it's fascinating. The brain's the most interesting thing in the world. So anyways, what am I basically saying is there is an excess of jobs and an excess of work to be done in radiology with very high salaries, but you will have to work like a maniac. But at least there'll be a job there at the end of the path. And I don't think AI is going to replace it. I think AI is kind of a big joke, and I actually think AI is totally being overhyped to use it as an excuse for firing people, and for, corporations are going to say, well, we've got AI now, and they're really just using that as an excuse for letting people go, not because they really need to. Anyways, we'll talk about that some other time. Hope you found this interesting and helpful.